All right, so we'll start by talking about some patterns of localized pulmonary blood flow. This we've seen before. What's the abnormality?
Enlargement of the main pulmonary artery and left pulmonary artery.
Right, and the right pulmonary artery is
Normal.
So what does this mean? What's the significance? Yeah, pulmonary valvular stenosis. So enlargement of the main and the left pulmonary artery, then we have pulmonary valvular stenosis, right? So that's one cause of asymmetry in the appearance of the pulmonary arteries there. So we've covered that before. So now the findings on this chest radiograph, what's abnormal?
Right atrium's enlarged. Oblique to the right.
Is it really oblique? I mean, how do you judge rotation? You look at the spinous process relative to the clavicles, right? So pretty straight film. So what's abnormal then? Why is there so much asymmetry from one side to the other? Just describe what seems to be going on.
The mediastinum shifted.
Yeah,
to the
so the
right.
mediastinum is shifted to the right. So why do you think the mediastinum is shifted?
Is there some like right-sided atelectasis?
Okay, so there's volume loss in the right lung, right? Is there atelectasis? I mean, do you see obscuration of anything? Is the heart border obscured? Is the diaphragm obscured? Not really, right? So it looks like the volume on the right side is decreased, right? Now, when you look at the vascularity, we notice that the left pulmonary artery looks somewhat enlarged, okay? So let's look at this a little bit further, and maybe a little bit of interstitially on the right there. But now there are things that can give you, decreased volume in the right lung. There are congenital things that can do it. You can have a hypoplastic lung. You can have hypoplastic vessels to that side. If you have, is this Swyer-James syndrome? Swyer-James syndrome is a cause of a small right. Right, it can give you a small right lung. Is this Swyer-James syndrome? Dan, is this Swyer-James syndrome? You don't know? So,
It's in a kid usually.
what is Swyer-James syndrome gives you what? Small.
On the left lower lobe.
It can be either side. But Swyer-James syndrome gives you small hyperlucid lung with air trapping. We don't have that here, right? This is not really a hyperlucid lung. So if we look at the CT, right, notice the right lung is smaller than the left. There's a movie to look at the vessels. When we look at the blood vessels, what do we notice here?
You don't see the right main pulmonary artery?
Yeah, so the right pulmonary artery is missing, right? So this is a congenital, so this is called proximal interruption of the pulmonary artery, right? So this can lead to a small right lung. It can also give you what looks like increased interstitial markings in the right lung. It's also prone to infection, so patients can develop bronchiectasis and other changes from infection on that side. And so how does the lung get blood supply if the pulmonary artery is missing proximally? What do you notice about?
There's a lot of collaterals.
What are these collaterals? What are these guys?
Bronchial arteries.
Yeah, those are bronchial arteries. So they're enlarged bronchial arteries. There's also an aneurysm in one of them as we go through it. So you see that there's enlarged bronchial arteries here, and right over here, right, there seems to be an aneurysm in one of them. Right? So this is proximal interruption of the pulmonary artery. So usually occurs between the pulmonary trunk and one of the pulmonary arteries. You'll have hypoplasia of the lung. The small branches distal to the interruption might be patent and fed by bronchial collateral arteries. And of course, that side is going to be hypoplastic. There are two categories of proximal interruption of the pulmonary artery. What are they? They can occur either on the side of the arch or on the side opposite the arch, which is worse. Okay, so we obviously need to review this. All right, interruption. On the side opposite the arch, that's usually the right pulmonary artery since the arch is usually on the left side. That's usually an isolated abnormality. Most patients can be asymptomatic. Some patients can develop pulmonary artery hypertension. If it occurs on the side of the arch, it's usually associated with congenital heart disease, especially tetralogy of flow, and obviously those patients would have a worse prognosis. So the pulmonary artery will appear small. This line, what is this line? Anybody know what this line is?
Is it bronchial artery?
No, it's not a bronchial artery. That's the anterior junction line. Because the right lung is small, the anterior junction line is shifted towards that side. And then you see these interstitial opacities. Some of them could represent the collateral, the intercostal arteries that can also enlarge. So the left pulmonary artery will be enlarged in this condition if there's interruption of the pulmonary artery on the right. Here's the anterior junction line, some interstitial opacities there. You might also have rib notching in these cases because of the intercostal arteries connect as collaterals here. So we can see the left pulmonary artery, non-contrast CT, but the right pulmonary artery is missing. And there's a small right lung, congenital interruption of the pulmonary artery. Here's the anterior junction line, small right lung, some interstitial opacities peripherally. Some of these represent collateral vessels that are supplying the lungs from the periphery. Okay. All right. So angiogram of the pulmonary arteries, what's abnormal?
Multifocal areas of stenosis.
Yeah, right. They're multifocal areas of stenosis, right? So areas of stenosis, branch stenosis in the pulmonary arteries. What can cause this?
Wagner's?
Well, in a child, especially rubella. So Williams syndrome can do it. Can be single, can be multiple bilateral, can be associated with other intracardiac problems. Usually results in pulmonary artery hypertension and right ventricular strain, but this can be associated with congenital rubella, branch stenosis of the pulmonary arteries. Can be treated if the lesions are proximal enough. They can be treated with balloon angioplasty. Okay. All right. Strange looking curvilinear opacity here, right? Here's a close-up. What do you suppose that might be? Yeah, so it looks vascular, right? Kind of lobulated. So of course, pulmonary AVM is something that you need to think about. So it is a vascular structure. You can see it's Hansen in the periphery like that. But it's very important when we see these is we want to be able to connect them. If it's a pulmonary AVM, you want to be able to connect it to a feeding artery and to a draining vein. In this case, actually, I'm able to connect this to a feeding artery. All of this seems to be venous, okay? So all of these are pulmonary veins, and it's eventually draining to the left atrium. Patient actually went to angiography. Here's the arterial phase, capillary phase, and you see that it opacifies on the venous phase. So what's the difference between the appearance here and what a pulmonary AVM would look like?
It would light up on all three.
Well, it would opacify earlier.
Right.
So the pulmonary AVM would opacify much earlier. This is opacifying on the venous phase. Right? So what do we call this? What is this?
Venous.
What's the term for this? If you have a tortuous vein, what is it called? Varix, right? That's a pulmonary varix. Pulmonary varix. Okay. Most commonly, they might involve the pulmonary veins, a dilated pulmonary vein at the insertion into the left atrium. So that can occur in anything that elevates left atrial pressure, like mitral stenosis. So pulmonary veins might be dilated at the insertion of the left atrium. Okay, so we can see that. That's the acquired form of pulmonary varix, all right? That usually occurs where the vein inserts on the left atrium from things that elevate left atrial pressure, right? So here's an example of a dilated pulmonary vein. And on the chest radiograph, it might appear as this retrocardiac kind of round opacity, marking the insertion of the pulmonary vein there. But there is a congenital form of these also, where you can have a dilated, serpiginous, elongated pulmonary vein that eventually drains to the left atrium. And sometimes it's one single large dilated pulmonary vein. So this is called pseudo-scimitar, right? What's the difference between this and scimitar?
Scimitar is partial anomalous pulmonary return
Right, so the pulmonary vein should go where?
to that EDC.
To the IVC, right. So this is called pseudo-scimitar. It's still draining to the left atrium, but you have a tortuous vein here. So this is a congenital form pseudo-scimitar, okay? So here we have an enhancing lobulated structure in the periphery, feeding vessel, draining vein. This is an example of a pulmonary AVM in this particular case. Pulmonary AVMs give you what kind of shunt? Right to left, yeah. So if there's a large amount of shunting, these patients can be cyanotic. What's a complication of pulmonary AVMs? Yeah, paroxysmal embolism, right. That's also a complication of pulmonary AVMs. So for a pulmonary AVM, you can see the feeding artery, there's the draining vein, so the AVM itself would opacify early in the angiographic phase. These are classified into two types. They are two types of pulmonary AVMs are simple and complex. Simple if there's a single feeding vessel, complex is if there's more than one feeding vessel. All right. Symptoms can be shortness of breath, cyanosis, hemoptysis, orthodeoxy in the upright position, because these tend to be at the lung bases. That can increase the blood flow in the upright position through the AVM, which can lead to hypoxia. Brain abscesses, that's because of the right to left shunting. The association Rondeau-Weber disease or hereditary hemorrhagic telangiectasia, which is autosomal dominant. In that case, there are multiple. So if you find one pulmonary AVM, very carefully look at the entire lung for additional lesions. Okay? So on the plain film, lobulated opacity, usually at the lung base, the plain film sign associated with it, you can see the vessels called the rabbit ear sign, right? So one of these is the feeding artery, one is the draining vein. Of course, easy diagnosis on CT or angiography, you can see the feeding artery and the draining vein when you have these pulmonary AVMs. Very important to look at the entire lung because these can be multiple, so if you find one, look for others, okay? They can be multiple in up to 30% of cases, especially if it's associated with HHT. Treatment, if the feeding vessel is greater than or equal to 3 millimeters, can be embolization, right? You want to make sure, though, that whatever you're using is large enough to include, because the last thing you want is for anything to go shooting through the pulmonary AVM. So that's our discussion of localized pulmonary blood flow. Let's move on to arch anomalies. So here we have a very prominent aortic knob here. It's kind of funny-looking structure here in the right paratracheal region. The lateral view, though, is very helpful in this case. So what's the finding on the lateral view? What is it showing you, and how does that help?
Tracheal narrowing?
Not so much tracheal narrowing as what? Tracheal bowing, right. The trachea is bowed forward. So there's an opacity back here. Whose triangle is that? Rader's triangle, right? There's an opacity back there in Rader's triangle. So we're talking about vascular issues here. So what is this going to be? What's the diagnosis going to be in this patient? Yeah, so this patient's going to have a left arch with an aberrant right subclavian artery. The aberrant vessel goes behind the trachea, behind the esophagus and the trachea, actually, to go from left to right. And so that can cause that posterior indentation of the trachea. Here it is. This is the left arch. This is the aberrant vessel. It goes behind the trachea and the esophagus. Okay? And in some cases, especially if it gets aneurysmal, patients develop atherosclerotic disease, it gets hardening of arteries. This can cause obstructive problems in the esophagus. That is called dysphagia lussoria, right? So obstruction of the esophagus or dysphagia from an aberrant subclavian artery is called dysphagia lussoria. In this case, another aortic arch, big dilated arch, some big thing here, this time in Rader's triangle, and this is actually an aneurysm of an aberrant subclavian artery back there. Okay? So the aberrant right subclavian artery, you do see this. Look for it on your CT scans. It's fairly common. So the aberrant subclavian arises as the last branch of the aorta, crosses from left to right, behind the esophagus, usually asymptomatic, unless the vessel is tortuous, aneurysmal, or there's a lot of atherosclerotic disease, in which case it can cause dysphagia of Lusoria. The diverticulum of Commerell is dilatation here at the origin of the aberrant right subclavian artery. So that dilatation is called the diverticulum of Commerell. Now, for all these arch anomalies that we're going to talk about, there's this double arch diagram embryologically. Remember, the aorta starts as a double arch, and then depending on where the interruptions occur, that affects the eventual morphology of what you have as far as the aorta. So we'll talk about some of these things and how we get these different variants of the aortic arch. So for formation of a normal arch, you start out with a double arch here. You get kind of involution, complete involution of this portion of the right arch over there. And then when that's all said and done, you're left with the normal configuration of the arch. So you have brachiocephalic artery, left common carotid, left subclavian, left-sided arch. The ligamentum arteriosum, because the ductus arteriosus on the left side, will also be on the left side. No vascular ring, right? No vascular ring normally with the formation of a normal left aortic arch. Now, when we have an aberrant right subclavian artery, what happens here is there's an interruption. The interruption occurs here between the right common carotid and the right subclavian. So then what happens is you'll have the right common carotid artery here, okay? You'll have the left arch, left common carotid, left subclavian, and then the aberrant right subclavian comes off, and again that can come off the diverticulum of Commerell here off to the right side. And again, the ductus arteriosus, the ligamentum arteriosum, is on the left side. That determines, by the way, where the diverticulum of Commerell is going to be, okay? And so, again, no vascular ring. So left arch with an aberrant right subclavian artery usually don't have a vascular ring there. But you can have a diverticulum of Commerell at the origin of the aberrant vessel. The finding, as we've seen on the plain film, can be that forward bowing of the trachea, but also on barium study, you will see this indentation on the esophagus. The posterior indentation on the esophagus here is caused by the aberrant subclavian artery. Okay? And so here, there's a left arch, and we follow it down. There's your aberrant subclavian. Okay, there it is, going across from left to right, and it goes across behind the trachea and the esophagus, and very common to see that narrowing of the esophagus. So you see the esophagus kind of collapsed where that vessel goes across. Okay? So here it is on your sagittal view. There's the aberrant subclavian artery. And the plain film, left looks, the frontal looks normal, but on the lateral you notice that forward bowing of the trachea. That's the hallmark on the plain film of an aberrant subclavian artery. Right? Okay, the chest radiograph in this case, what's kind of unusual looking about this chest radiograph? Yeah, this time we have a right aortic arch, right? So there's this right paratracheal opacity. When we look on the lateral view, what do we notice? Yeah, so again, the trachea is bowed forward. What does that tell you? Well, what did we say? What did we say it means? If there's an opacity in Rader's triangle, if we're talking this electron vascular issues and there's forward bowing of the trachea, it means you have what? You have an aberrant subclavian artery. So which subclavian artery is going to be aberrant this time? Left. Yeah, so if you have a right arch, you can have an aberrant left subclavian artery. So that's an aberrant left subclavian artery. So here's the right aortic arch. Here's the aberrant subclavian artery here coming off. Going across again here from right to left, behind again the esophagus and the trachea. And again, we can have a diverticulum there at the origin, a diverticulum of Commerell at the origin of the vessel. Okay. Here we have this widened mediastinum, of course, the differential lymphoma, tumors, all of that stuff, but we're talking about vascular issues here. And we notice that the patient has a right aortic arch, but the descending thoracic aorta is on the left side. So this winds up, wrapping around here, the trachea and the esophagus. Okay? So this is called a circumflex aorta. This can also cause issues with dysphagia, right? Circumflex aorta, where you have a right arch, but the descending aorta can be on either side. In this case, it's descending on the left side, and that also causes this wrapping around here. You have vessels wrapping around the trachea and the esophagus. Okay? Again, the ligamentum will be on the left side in these cases. Another patient with a right aortic arch is the chest radiograph. What kind of right aortic arch is this? Well, what's the first branch here coming off? Yeah, that's the left brachiocephalic artery is the first branch coming off. Right? The next branch, right common carotid, and then right subclavian. So what kind of arch is this? What do we call this? So this is called a mirror image right aortic arch. Right? This is the mirror image of normal in terms of the branching of the vessels. So what is nicely illustrated on the chest radiograph? What is the significance of mirror image right aortic arch? What is mirror image right aortic arch associated with? You should know this. You were looking at cases with Dr. Fatak, weren't you? So what did I hear out there?
Tetralogy?
Congenital heart disease. In this case, it's tetralogy of flow, right? So you have the boot-shaped heart, decreased pulmonary blood flow, right aortic arch. So mirror image right aortic arch is usually associated with congenital heart disease, especially tetralogy of flow. We talked about two congenital heart diseases that are associated with right arch. One of them is tetralogy. The other one was truncus arteriosus, right? Both of those can be associated with mirror image right aortic arch. So the significance of mirror image right arch is, especially in children, pediatric infants, think about congenital heart disease, okay? So, chest radiograph, another patient with right paratracheal opacity, so in this case, again, a right aortic arch, right? But the angiogram is kind of peculiar. What's peculiar about the angiogram?
There's not really a left subclavian, it will show up late.
Yeah, the left subclavian shows up late, right? So why is it showing up late and how is it filling?
Retrograde flow,
From?
cerebral circuit?
So what's coming down retrograde to fill the left subclavian? Yeah, the left vertebral artery. So you'll see the left vertebral artery will be coming down and filling it. So we'll see that in a second. So the branches that you see coming off the aorta, this guy is what?
Left common.
Yeah, so that's the left common carotid. Then you're going to have the right common and the right subclavian. But the subclavian here does not seem to be connected to the aorta, right? So here's a selective injection of the carotid artery, and you can see the subclavian coming down, right? So of course this can occur if you have severe atherosclerosis, but this is a young person, right? So this is called congenital subclavian stele, right? So this is the rarest form or very rare variant of right aortic arch. This is another form of right aortic arch. In this particular form, the subclavian artery has lost its connection with the aorta. And so this is congenital subclavian stele. How does it fill? It fills retrograde through the vertebra. So when you notice a patient with a right aortic arch, it's very important to look at the branch vessels to decide what kind of right arch are we dealing with? What kind of right arch do we have? So this form is called right arch with interrupted or isolated left subclavian artery. It's filling the vertebral artery, congenital subclavian stele. Okay. So right aortic arch. What are the things we need to know? The side of the arch, an easy way to think about this, is determined by its relationship to the trachea. Where is the arch relative to the trachea? That tells you, is it a right arch or a left arch? Find the arch, is it to the right or to the left of the trachea? If it's to the right, then it's a right arch. Think of an aberrant subclavian artery as being the last of the great vessels to come off the arch. The aberrant subclavian is always the last vessel, right? If there is an aberrant subclavian, it's usually on the side opposite the arch. So if you have a right arch, you can have an aberrant left. If you have a left arch, you can have an aberrant right. So it's usually opposite the arch. Now, the three types of right aortic arch you need to know. Right arch with aberrant left subclavian artery, that is the most common. Usually no associated congenital heart disease. This is the type you will see in adults. Okay. Mirror image right-sided arch. This one is associated with congenital heart disease. We talked about tetralogy, flaw, and truncus. Right. Mirror image right arch. Right arch with isolated left subclavian. This is much rarer than these two, but this you will, occasionally you come across these. Right. So it's very important when you see a right aortic arch, follow the vessels. What kind of arch is it? Right? You don't want to miss this. Right arch with interrupted or isolated left subclavian. So tetralogy of Fallot, right arch with aberrant left subclavian artery. Less than 12% will have congenital heart disease. So here are some of the congenital heart disease that might be associated with that. But for all intents and purposes, if you have an adult patient with the right arch, it's usually going to be a right arch with an aberrant left subclavian. If the patient's asymptomatic, then there's no congenital heart disease. Mirror image right aortic arch, that can be associated with tetralogy or truncus. So most cases, especially children with mirror image right aortic arch, infants, that's associated with congenital heart disease. The right arch with the aberrant left subclavian, that's the most common that we see, especially in adults, low incidence of congenital heart disease. We've talked about the retroesophageal course of the arch. There can be a vascular ring if there is a left ductus connecting to the left subclavian, although it tends to be a loose ring. So these patients are usually asymptomatic. So how does this occur? So here's your double arch model. Interruption occurs here, okay? And so you're left with a right arch with an aberrant left subclavian artery. The ligamentum is on the left side, so you do form a vascular ring, but this tends to be a loose ring, which is why these patients tend to be asymptomatic as far as obstruction of the airways or the esophagus goes in these cases, okay? And then the signs of a vascular ring always you'll see two indentations on the esophagus, especially in pediatric cases when you have a vascular ring. You see indentations on the esophagus because it's completely encircled by vascular structures. So, right arch, aberrant left subclavian, diverticulum of Commerell here. Okay. Most common, vascular ring, although the ring tends to be loose, usually not symptomatic. And the ductus dimple, usually, if the ductus dimple is on the side opposite the arch, you usually have a vascular ring. So if the ductus is opposite the side of the arch, usually you have a vascular ring because that's where the ligamentum is going to be opposite the arch. And if the ligamentum is opposite the arch, then you have a ring. Here's a patient with a circumflex right arch with the circumflex aorta coming around here. And you can see how it forms a vascular ring around the trachea colored in blue there. And then here's the ligamentum colored in red for you to see. Notice the diverticulum of Commerell. Now, why is there a diverticulum of Commerell? Why do we get this dilatation of the blood vessel in this region?
Does that have to do with the degenerative process of that arch? Just leaves the diverticulum behind?
Well, it has to do with this. Remember, in embryology, this is a patent ductus arteriosus. So what happens is there's increased blood flow through this region. Where there is increased blood flow embryologically, usually the vessel is somewhat dilated. Right? So there's increased blood flow here in utero. So the vessel dilates here, and then it goes through the patent ductus. That here you just have the regular, subclavian that's coming off up there. So then that doesn't dilate, but that's the reason you get a diverticulum of Commerell. So it occurs where there's the ligamentum arteriosum because of increased blood flow in utero through there, because it's a patent ductus at that time. So mirror image right arch, congenital heart disease, especially tetralogy of Fallot. Mirror image branching is just the mirror image of normal. Especially in infants, it's almost always associated with congenital heart disease. This does not form a vascular ring with mirror image arch. The interruption occurs here. You get mirror image of normal. The ligamentum you see is on the left side, but it's anterior to the trachea and the esophagus, no vascular ring. So mirror image arch does not give you a vascular ring. Okay. Right arch with isolated left subclavian. So we've covered that. We've talked about the order of branching. So the subclavian loses its connection to the aorta, right? So how does that occur? Well, it turns out there are two interruptions, one here, that winds up isolating the left subclavian, and then it may connect in utero to the pulmonary artery through the ductus arteriosus. Okay? But then when that closes, you're left with an isolated subclavian artery, and then it will fill from the vertebral, so congenital subclavian stele. Right? So, what's funny looking about this chest radiograph? Notice anything about the trachea?
It looks pinched.
Looks what?
It looks pinched right at the level. of
Pinched,
the
yeah,
aorta.
right here, there's a little bit of narrowing of the trachea, right? So, what's going on? So what is this guy?
Left side aorta.
Yeah, that's a left aortic arch, so that causes a normal indentation on the trachea, so you would expect that. But what's causing the indentation on the right?
Vascular ring.
Yeah, from what? There's an opacity here in the right paratracheal region. Right? So what does this patient have?
The double arch.
This is a double arch. This is a double aortic arch. So this is the most common symptomatic vascular ring. Persistence of the double arch is the most common symptomatic vascular ring. Easy diagnosis, you'll see two arches. The ascending aorta splits into two arches. They then combine into the descending aorta posteriorly. There's a symmetric takeoff of the carotid and the subclavian from each arch, just above this level, right? So this is persistence. This is double arch, double aortic arch, right? And this true vascular ring here causes narrowing of the trachea, and this can cause obstructive symptoms in infancy, double aortic arch, right? So no interruption, so there's just the persistence of the double arch. Most common vascular abnormality to cause compressive symptoms in infancy is the double aortic arch. The right arch is usually larger, higher, and more posterior than the left arch. In some cases, the left arch may be atretic, but that becomes very difficult sometimes to figure out, what's happening when that occurs. The aorta usually descends on the left side. Interestingly, this is not associated with an increased incidence of congenital heart disease. It's usually an isolated abnormality when you have a double aortic arch. So you'll have the indentation there on the esophagus. See the double arch here wrapping around the trachea and the esophagus, and then it unites posteriorly into the descent of the base of the aorta there. Okay? So notice the right arch usually larger and higher than the left arch when you have a double aortic arch. They unite posteriorly to form that single descent of thoracic aorta. And then two indentations on the esophagus. Whenever you have a ring, you'll have two indentations there on the esophagus. Okay? And then that posterior indentation also, you also see that with a vascular ring from double arch. Okay? And then just when you think you finally understand all this, you get a case like this. We have a 28-year-old with the right aortic arch, no evidence of congenital heart disease. What kind of arch should this be? What should this be? Exactly, right. So this patient should have a right aortic arch with an aberrant left subclavian artery. Okay? What does he have?
Mirror image branching.
Yeah, so this is a right aortic arch with mirror image branching. Now we just talked about this, right? Mirror image branching is supposed to have what? Congenital heart disease, right? But here's an adult patient with the mirror image branching who does not have congenital heart disease, right? Mahi, were you with Dr. Fatak when you looked at a case like this?
I didn't look at
You
something
didn't
like
see
this.
you
No,
didn't see a case like that?
unfortunately.
So what's going on here? How do we explain this, right? Mirror image branching. An adult with mirror image branching who does not have congenital heart disease. Right? So in this particular variant, what we find along the descending thoracic aorta, you will see this retroesophageal diverticulum, and the embryology explains what's going on here. We'll get to that in a second. But when you have an adult with mirror image branching and no congenital heart disease, look for this. You will find this retroesophageal diverticulum coming off the descending thoracic aorta. So what does that represent? What's going on here? There are two types of mirror image arch depending on where the interruption occurs. Mirror image type 1, the interruption occurs here, proximal to the ductus arteriosus or ligamentum arteriosum. That gives you mirror image branching associated with congenital heart disease. Mirror image type 2, the interruption occurs just distal here to the ductus arteriosus. This type is not associated with congenital heart disease. And then the hallmark of this is that little diverticulum that's left over from the descending thoracic aorta that pokes out. All right? So you can see that on the CT when you look at these cases. So embryologically, what's happening here, the interruption occurs right here, okay? And then it occurs distal to the ligamentum arteriosum here. So there's a little outpouching over here, right, from the descending aorta, that little diverticulum. So these patients do have a vascular ring. They will have a vascular ring. Again, this tends to be a loose ring, so they're usually not symptomatic. But they do have a vascular ring, not associated with congenital heart disease. So the difference between mirror image type 1 and mirror image type 2 has to do with where the interruption occurs. If the interruption occurs proximal to the ductus arteriosus, they get mirror image type 1, no vascular ring associated with congenital heart disease. If the interruption occurs just distal here to the ductus arteriosus, that's mirror image type 2, no congenital heart disease, that causes a loose ring. The hallmark of this, on your imaging study, in addition to the mirror image arch, is that there will be this little outpouching in the descending thoracic aorta, that little ductus, that little diverticulum. And so that marks where the ligamentum arteriosum is, okay, going to the pulmonary artery, that little outpouching, right? So that's mirror image arch, type 2. All right, this patient has breathing difficulty, okay? And when we look at the lateral V, we notice there's some narrowing of the airway, right? And there's some imaging on the patient. So what is causing the narrowing of the airway?
There's a vascular indentation of the anterior.
What is that vessel causing that indentation? Right, there's a vessel here causing the indentation. And notice also, you can see the trachea is narrowed here, okay? So what vessel is causing this? What is this called? Anybody know what? It's not an aberrant vessel. It's not a pulmonary sling, no.
Prominent, innominate.
First of all, why isn't that a pulmonary sling? All right, well, we'll get to it. Right, so this is innominate artery compression syndrome. So this occurs from the innominate artery rising just a little bit more distal than normal, and so when it crosses over, it crosses anterior to the trachea, causing compression of the trachea. So this can cause respiratory distress, wheezing, stridor. So that's called innominate artery compression. Okay, so the innominate artery starts out a little bit too far to the left, and when it crosses over, it compresses the trachea. All right, so that's innominate artery compression syndrome. And it can also be associated, because this is present in utero, it can be associated with tracheomalacia, abnormal formation of the trachea from innominate artery compression. Similarly, there's anomalous left common carotid artery that can also occur. If that arises more proximal than normal, when it crosses over, that can also cause a compression along the anterior border of the trachea. Okay? So in infants who have narrowing of the trachea, in addition to looking for rings, vascular problems, also look for the relationship of the innominate artery and the carotid relative to the anterior trachea. Okay, what am I showing you here?
Pulmonary sling.
Yeah, so this is the pulmonary sling. So this is the innominate left pulmonary artery coming off the right. When it crosses over, how does it cross over? It goes between what two structures?
Trachea.
Yeah, between the trachea and the esophagus, right? It's said to be the only vascular malformation that leads to a vessel crossing between the trachea and the esophagus. Okay, so that is the pulmonary sling when it goes across. This is also associated with respiratory problems from narrowing of the trachea. So you can see here where the vessel goes across, it goes across between the trachea and the esophagus, and it can cause narrowing there of the trachea where it goes across. So that is the pulmonary sling. Okay, the hallmark on a barium study is that indentation between the trachea and the esophagus. So that is the pulmonary sling. You see that? That's a pulmonary sling. Left pulmonary artery coming off the right, going across between the trachea and the esophagus, and that can cause compression of the trachea. And the right bronchus can, again, with any of these, there might be abnormal formation of the trachea in utero also, which can cause problems with the trachea and stenosis. So here you can see the left main bronchus here is narrow in this patient who has a pulmonary sling. So this one can also be associated with a small left lung. Small left lung, there's an indentation there. And more examples, so make sure you can recognize that. It's a pulmonary sling, if we see that on a barium study. And then here it is on MR. You can see the vessel going across between the trachea and the esophagus. And nice volume rendered view showing that here. Now they can also have abnormal blood flow because that pulmonary artery can be small. If you look at the pulmonary blood flow with phase contrast MR, here you're looking at the right pulmonary artery and the left. Notice there's more blood flow through the right pulmonary artery than there is through the left, right? So this can also be associated with decreased perfusion of the left lung. That can be another reason why the left lung can be small in these cases. So pulmonary sling, okay? So the things to remember as far as compressions, vascular ring, usually two compressions. You can have a compression anteriorly on the trachea and a compression posteriorly on the esophagus. Anomalous innominate, this causes an anterior indentation on the trachea. Aberrant subclavian artery causes a posterior indentation on the esophagus. And the pulmonary sling, if you have an indentation between the trachea and the esophagus, that is a pulmonary sling. Okay? So that's our discussion of rings and slings.